like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. I got my head held high, I'm on my way, and I'm following the signs to my happy place. I'm walking in the light of a brand new day, and I'm right where I belong in my happy place. And I'm right where I belong in my happy place. And I'm right where I belong in my happy place.
Thanks for joining us and welcome to the National University of Singapore Yong Lin School of Medicine Healthy Longevity webinar series. I want to remind you to use the Q&A function if you have questions in tonight's presentation, and we will try to get to those near the end of the talk. This is an exciting show tonight for a couple of reasons. First of all, it is one of our very own speakers from the Healthy Longevity program here at NUS, Christopher Chen, who'll be talking tonight, so that's exciting. And second of all, this is the first show that we're really devoting to dementia. So we'll be talking about vascular dementia and AD a little bit tonight. So that's one of the main things people worry about when they think about aging, and so we'll try to dig into that a little more and give you some information on that. And similarly, the presentation of a recent paper in the field by Joyce Chong will be focused on dementia as well, looking at different associated factors in an Asian cohort of Alzheimer's disease patients. Joyce?
Hi, everyone. As introduced by Prof. Brian, I'm Joyce from the Department of Pharmacology, and under the main supervision of Dr. Mitchell Lai, as well as the co-supervision of Dr. Christopher Chen. The paper which I'm presenting on today is plasma p-tau to A-beta-42 ratio is associated with brain amyloid burden and hippocampal atrophy in an Asian cohort of Alzheimer's disease patients with concomitant cerebral vascular disease. This paper has been published in March this year in Alzheimer's and Dementia. Dementia is one of the major causes of disability and dependency among the older people. Its risk increases with age. In the local context, in Singapore, based on information from Health Hub, about 1 in 10 among the elderly suffers from dementia, and this corresponds to 82,000 people with dementia in 2018, and a number that is projected to increase to 152,000 by 2030. Alzheimer's disease, in short AD, is the most common form of dementia. Its key pathological hallmark is the presence of protein aggregates in the brain, namely the amyloid plaques composed of A-beta-42 and A-beta-40 peptides, and neurofibrillary tangles, which compose of hyperphosphated tau protein, in short p-tau. These key pathological features, there have been targets for AD biomarker development, which holds promise for the early as well as accurate detection of the disease. And we think that this is actually important given the recent FDA approval of aducanumab for the treatment of AD, as well as promising results from a few other disease-modifying trials. And in this aspect, recent studies in the white populations have demonstrated that the blood p-tau may be a potential biomarker that is specific for AD pathology. However, the utility of this biomarker in non-white cohorts with significant cerebral vascular disease remains largely unknown. And we think that this is important because the prevalence of AD as well as CVD may be higher in specific geographic regions, such as in Asia, and this have implications for the prevention, diagnosis, as well as prognosis of the disease. Therefore, using a Singapore-based cohort of AD and vascular cognitive impairment patients, this current paper aims to address this knowledge gap. There are plenty of information on this slide. However, we may just focus on the key results. As mentioned, this is a Singapore-based cohort which included subjects with no cognitive impairment, in short NCI, cognitive impairment, no dementia, CIND, Alzheimer's disease AD, as well as vascular dementia VAD. And as expected, a good majority of 68% of the AD patients have elevated brain amyloid burden. And looking at the white matter hyperintensities volume, which is a marker of cerebrovascular disease, we can see that it's significantly increased in subjects with CIND, AD, and VAD. And next, we look at the really exciting results on the plasma biomarkers. We're just going to focus on p-tau 181 as well as the p-tau 181 to A-beta 42 ratio. And we can see that these two blood biomarkers are increased in the CIND and AD, but not in the VAD. So this raises the next question of if the increase in these blood biomarkers may be associated with the pathology. Thus, we next stratify our patients into their diagnosis as well as their brain amyloid status. And we just want to inform everyone that the presence of elevated brain amyloid burden is represented by the A-beta positive symbol in the figure. And if we just look at within the CIND and AD, we can see that the two biomarkers are higher in subjects with the elevated brain amyloid burden as compared to those without. So what this suggests is that the blood biomarkers are associated with brain amyloid burden. And over here, what we are trying to do is to assess the performance of these two biomarkers to identify subjects with elevated brain amyloid. And for this slide, we just have to focus on the AUC, where a higher AUC indicate a better performance of the blood biomarkers to distinguish between subjects with and without elevated brain amyloid. As we can see from the slide over here, the p-tau 181 to A-beta 42 ratio is consistently the best biomarker in identifying elevated brain amyloid, both in the combined cohort as well as in the non-dementia subgroup. So overall, our results suggest that the p-tau 181 to A-beta 42 ratio may be a clinically useful, non-invasive means of identifying individuals with high amyloid burden in Asian populations with high baseline cerebrovascular disease. And we just want to thank you all for your kind attention and handing the time back to Prof. Ryan.
Thank you. So that's a nice preview of your work, Chris. Let me introduce you before I turn it over to you. So Christopher Chen's major research interests are neuroimaging, molecular biology, and treatment of stroke and dementia. And excitingly, he's just had a successful consortium of research groups and secured a large collaborative grant that's going to allow him to do an intervention trial that he'll be describing tonight. So Christopher, we're excited to hear what you're going to do.
Thank you very much, Brian, and thank you so much for inviting Joyce. So she didn't tell me she was going to present, and I'm really so proud of her. The wonderful work that she and Mitchell are doing in our lab. Brian, thank you so much for giving me the opportunity of talking about our work. As you say, we've been given the opportunity by the NMRC to do a large intervention study, which also includes mechanistic studies. And we've called this the SINGER study. It's the Singapore GERiatric Intervention Study. We reduce not just cognitive decline, but also physical frailty. So the first thing I'm going to say is that I come from the Memory Aging Cognition Center at NUHS. And we have several arms, biomarker discovery, neuroimaging, clinical and epidemiological studies. And the NMRC has funded us for the last decade. And all the work that I'm going to describe has been done, obviously, by a large group of people. And this is a not very recent picture because we actually haven't been able to meet, as all of you know, for the last 2 years now, to go and take a group photograph. So I wish to go and thank everybody in advance. Okay, so why are we so interested in this? I don't think I need to tell this audience that aging is a huge issue, and it's a particularly massive issue in Asia. And one of the biggest challenges, as Brian has mentioned, is going to be dementia. The largest increases due to rapid aging and large populations in dementia burden will be in Asia. So we have a huge challenge in how we're going to prevent cognitive impairment and dementia. And there has been a lot of excellent work done. And I would urge all of you to go and read this wonderful paper by the Lancet Commission on dementia prevention and interventions. And basically what they have described is a number of risk factors which are possible to intervene upon, and they've calculated how much it affects the risk for dementia. And I think the important figure to go and note is that if we could do something about all these risk factors, we could potentially modify about 40% of the risk for dementia, which is, really much better than any other possible treatment that we can think of. Now, of course, some of these risk factors occur in early life, for example, education. So we obviously want to improve education for everybody, but it may be a bit late for us right now to intervene in people in the middle age and late life. But in these age groups, there are also many factors which can be worked on. And I think that you can see that many of these factors are lifestyle factors. And this is why the World Health Organization has promulgated these set of guidelines to say that there is a reasonable amount of evidence to say that physical activity, stopping smoking, nutritional interventions, cognitive interventions, etc., management of vascular risk factors like hypertension and diabetes, dyslipidemia, may reduce the risk of cognitive decline and dementia. But the problems are that we still don't know how best to do them, how best to intervene. Methods are not harmonized. We don't have predictable results. We don't have information from many non-Western, low and middle income countries. We are not sure whether we can intervene both for midlife and late life risk factors. There's a paucity of long-term randomized controlled trials. And of course, very few trials have investigated multi-domain interventions, as has been suggested is the best way forward by the epidemiological studies. Hence, the role of worldwide fingers. Now, this group of researchers, and you'll see why we're calling ourselves worldwide fingers later, has made the argument that multi-domain interventions are going to be very important for preventing cognitive impairment, Alzheimer's disease, and dementia. Because Alzheimer's disease and dementia, it's itself a complex, multifactorial, heterogeneous group of diseases. And so we probably need interventions targeting several risk factors. I know we're all very excited that the first disease-modifying drug targeting amyloid has been approved by the FDA. But those of you who follow the literature know that this treatment does not reverse dementia. It just slows down the progression. So it's not the only answer. We know that modifiable risk factors of dementia include many lifestyle-related factors, and randomized controlled trials are needed to clarify whether modifying these factors can prevent, postpone cognitive impairment and dementia. So some trials have been done. Some of you will know that the Dutch did a trial called the PREDIVA trial, where there was cluster randomization of GP practices, and this was a nurse-led multi-domain vascular care intervention, which unfortunately showed no difference in the cumulative incidence of dementia. Another trial performed in Europe, the MAPT study, also randomized patients between multi-domain interventions and a dietary supplement. And again, unfortunately, they found that there was no difference between the groups and placebo. Although a post-hoc analysis subsequently suggested that multi-domain interventions may be superior to placebo alone. However, the field has been really informed by this finger study, which was done by colleagues in Finland, near Kivipelto and colleagues. And what they did was that they put together an intensive multi-domain intervention, which included nutrition, exercise, cognitive training, and monitoring and management of metabolic and vascular risk factors. And they put people through it for 2 years versus regular heart health advice. And the results were quite astonishing. Not only did they show that there was a significant difference in the overall cognitive score, but there was also differences between the control group and the active group on executive functioning, processing speed, as well as complex memory tasks. So when this trial came out in the news, it led to a lot of excitement. In fact, it led to so much excitement that Ed Koo, who used to be here with us as star investigator, and I was summoned to go and speak to the CEO of NUHS and ask why were we not doing a similar trial. And the reason for that is that many people felt that finger was not feasible outside Finland. Now, some of you will know that the Finns live in a very cold country and they don't like wearing clothes. And by comparison, Singaporeans are very keen on their food and very keen on and the fact is that they're multi-ethnic compared to the Finns. And there are several differences, but there are also similarities. You know, Singapore and Finland are roughly the same size in terms of population. They value education. They have a lot of MPs, and we both love saunas, one being indoors, the other being open air. So this led us to go and to meet up with the principal investigator of fingers, first in 2016, to form this global consortium, Worldwide Fingers, in 2017, and then further visits by myself to Finland in 2017 and 18 to see how they performed the trial and whether we could perform a similar study in Singapore. And we started a Singapore pilot study in 2018. One of the revelations when I visited Finland was when they took me to have a Nordic diet meal. And it turned out that what the meal was, you may not see it so clearly here, was fish curry. So I immediately thought, I think we can do it. So the Singapore pilot study was based on finger, and we had excellent help from Jer Henry, Effie Chu, my colleague Summer Shu, and with funding from Brian, so Brian, thank you so much, we were able to do this pilot study, which has been published recently. What we did was that we compared in a small group, elderly Singaporeans, the finger interventions versus Singaporean adaptations. The study design was very simple. We randomized eligible moderately or mildly frail subjects with different degrees of cognitive impairment, but not dementia, into either a multi-finger lifestyle intervention or SINGER, and we saw them at 3 months and 6 months. What's the differences between SINGER and finger interventions? So for vascular management, SINGER actually saw the patients and we managed all their vascular risk factors, whereas this finger protocol meant that you wrote a nice polite letter to the GP to say that they should manage this patient's vascular risk factors. In terms of cognitive training, SINGER was pen and paper because we were worried that elderly Singaporeans would not take to computer-based cognitive interventions as was done in the finger study. In terms of diet, you can see on the right the healthy Nordic diet versus an adaptation for Singaporean tastes. So Singaporean fruits, for example, Singaporean whole grains, low-fat soy milk rather than milk, etc. And you can see this is very doable. And in terms of exercise, both exercise regimes shared a supervised exercise class, and the main difference was that in finger, there was unsupervised aerobic exercise, but in SINGER, there was supervised aerobic exercise, because we weren't sure whether elderly Singaporeans would go out into the woods and exercise as the Finns did. A busy slide basically showing that the sample characteristics, even though the trial was quite small, was pretty well matched between two groups. And in terms of the primary outcome, which was feasibility, attendance and compliance was pretty good across all the interventions, with the exception of cognitive training, where unfortunately, because many subjects in the finger group could not get access to to computers, attendance and compliance dropped. In terms of efficacy, again, probably because the study was short, we couldn't find any real differences in terms of physical outcomes. And the only real difference was in blood pressure control. So this slide illustrates that subjects who had poor baseline blood pressure control did much better if they were in the SINGA arm compared to the finger arm. And there was no difference in terms of cholesterol or diabetic outcomes. So we concluded that the favored interventions, contrary to what everybody expected, was actually finger in the physical, the cognitive, and the diet sections, because the finger was already established. And the only exception was the vascular component. Now, yes, it's true that in the cognitive arm, feasibility was lowered for finger because of lack of computer equipment, but we have plans to overcome this. So we very rapidly went on to try and see whether we could develop a larger study. We wanted to do, since we showed that the finger and SINGA interventions were feasible, a much larger study recruiting 1,200 community-dwelling elderly at risk of dementia for a 2-year intervention program to randomize them between self-guided lifestyle management and a structured lifestyle intervention. And in addition, we plan to investigate many biomarkers to establish what, if any, were the mechanisms behind any differences in the two groups. So as Brian said, we were successful in persuading the NMRC of the merit of our program, and we were funded last year for a large collaborative grant. And I'm very grateful to all my colleagues across Singaporean institutions, as well as abroad, for coming together and making this possible. So what are we going to do? Oh, sorry. I should also say that what we're going to do has very much been affected by COVID. So the pilot study was affected at the tail end of COVID, but we managed to overcome it through a dint of teleconsultations and home visits. But it has affected what we conceive of how we're going to manage this trial. So because of safe distancing and social restrictions, which we think will be the new normal, we're going to have to, we are developing appropriate methods to recruit, intervene, assess, and retain subjects in a new world. So we're going to rely on digital recruitment and consent, web-based study materials, digitizing our assessments, using podcasts and apps for distance communication, and limiting face-to-face assessments to the minimum. And I think this is especially important now because we realize that COVID affects the brain. It may damage it directly and indirectly, making a study like SINGA all the more relevant. The digital platform we hope to develop will not only help us to monitor health, but also to evaluate and predict for patients' performance, to give them educational content and advice, and to improve communications. So the study design, again, is simple. We're going to randomize 1,200 subjects between a self-guided arm and a structured lifestyle arm. They're going to be seen at baseline, at month 12, and at month 24. This is the busy slide showing how intense the structured lifestyle intervention is. We're going to sort of bring people in for cognitive training, for physical training, nutritional counseling, and they will get appropriate vascular management. By contrast, the self-guided intervention is what we call a do-it-yourself intervention. Subjects will be given a tablet with material, educational material. There'll be pre-recorded materials, and we will give them their results of their blood tests and their vascular risk factor assessment for them to go and sort of manage themselves with the help of their general practitioners, of course. In terms of the intensive arm cognitive training, we'll utilize the finger platform. We'll also use the digital platform to link with our subjects to help them understand what they're supposed to do, and to also help them to remind them to do the cognitive training. For physical intervention, we have linked up with partners in the community, and we're very grateful to the strong support we've got from HUR, the Helsinki University research arm, which produces some really fantastic gym machines, as well as Active SG, which has gyms all over Singapore, and remarkably have agreed to let us use this very bright and airy space in their new Kallang center. So we are greatly indebted to our colleagues in the community for making all this possible. Physical intervention will also rely on Zoom material. Yes, the current material uses svelte young ladies, but I've been persuaded to perform in these videos myself as an example of an elderly, out of shape male. So I think that would probably arouse perhaps more enthusiasm. The diet intervention, we are also going to go and bring people in for Zoom meetings, teach them about nutrition, and also to go and sort of have not just group talk, but also individual sessions. And we will be monitoring patients' adherence to their diet. And finally, we're going to be doing, as I said, a lot of biomarker work. So in addition to MRI, to look at brain changes, we're going to be doing retinal imaging to look at blood vessel changes, as well as retinal nerve fiber changes. And we're going to be using these blood biomarkers that Joyce mentioned to see whether we can affect mechanisms of neurodegeneration. So we are really looking forward to do this trial. It's really opened my eyes as to how we can work in the community for healthy longevity. So you can see here pictures of us visiting the Bishan Community Center, where they have a gym with some really wonderful staff. And we also went to see how Bishan is putting gyms everywhere in the housing estate. So you're never more than 400 meters away from somewhere to exercise. So I think these kinds of initiatives are really wonderful to see. And I think that SINGA can help us best utilize these facilities. So I'm just going to end, if I may, by discussing some alternatives. Those of you who attended Andrea Meyer's talk on her work on gerontology 2.0, you would have seen a slide with her saying that, physical exercise works, let's just implement it. But I think that we need to recognize that key stakeholders, such as politicians or healthcare managers, although they may think there's sufficient evidence for effectiveness, many researchers take a different view, because really the gold standard for whether any intervention is efficacious and safe really requires a randomized controlled trial, if it's possible. And just simply implementing intervention may have issues with feasibility, accessibility, and people will question whether it's really value for money, because all these issues cannot be proven to everybody's satisfaction without trials. There may also be issues with the communities that you put these interventions in, because if you're going to do a study which is not well founded, people may object to being in the control group or object to be randomly assigned to programs. Furthermore, there may be constraints in terms of logistics, as complex interventions such as multiple lifestyle interventions can rarely be implemented en bloc and really need to be rolled out sequentially. So there have been several ways to address these issues, and these include cluster randomization trials, where you split groups up into different clusters and you randomize them to different interventions. And more recently, what is called a step wedge study design, where increasing numbers of sites turn over to active intervention. But running such trials pose their own issues. And in particular, step wedge designs have become very problematic during the COVID pandemic, because having lockdowns and lack of access to facilities means that you can't really roll out for intervention. So I still believe that there is a need for rigorous randomized controlled trials involving lifestyle interventions such as SINGA, and we really hope to make this happen over the next couple of years and bring well-founded results to change our lifestyles in the near future. Thank you very much.
Great talk, Christopher. It raises one really important question. These exercise videos, are you going to make them available to the general public, or do you have to be a participant to see them?
Well, we will put them on YouTube, but I think they're going to be private. You're keen on seeing me in Lycra, Brian?
Yeah, well, we have these videos at the end of the show, and I think one of the future shows, we're going to feature you in the video, if that's okay.
I'm looking forward to it. I don't think anybody else is.
So maybe since it's our first show on dementia, I can ask some general questions that a lot of people in the audience probably have. And one of them, is when my grandmother started to become impaired as she got older, they just said, oh, she's senile, it's normal with aging. And then, of course, we went to defining Alzheimer's disease, and now we have vascular dementia and Lewy body disease and a whole range of other things. How many different conditions really are there, and how similar are they? Do we know that, and how do we differentiate them?
Excellent question, Brian. I think that fashions in dementia move to and fro. So there was a time not so long ago, maybe 100 years ago, where everybody thought that dementia was due to vascular disease, atrophy of the brain due to shriveling of your blood vessels. And then Alzheimer came along, and later on and he thought that Alzheimer's disease was just a pre-senile dementia, something that happened in younger people. But the neuropathologists got into the act, and in the 60s and 70s, they showed that most everybody with dementia had amyloid plaques and tangles. So the pendulum swung from vascular dementia to Alzheimer's disease. Now, of late, what we've discovered is that because we can now do in vivo imaging, both using MRI and with PET and with blood biomarkers, that it is more complicated than that. That it turns out that most people don't just have one cause of dementia. Most people have both neurodegeneration, Alzheimer's disease, as well as vascular changes. And even in patients that you diagnose very confidently using clinical criteria to have Alzheimer's disease, somebody with slowly progressive memory problems, very poor short-term memory, shrinkage of the brain, etc. When you do PET imaging, for example, it turns out that about 20 to 30% of these people diagnosed with Alzheimer's disease don't have significant amount of amyloid. They have something else. Now, what this something else is, as you rightly point out, includes Lewy body disease, how a predominant disease, and other forms of diseases. So we're still learning.
While we're on the topic, I think a lot of the early trials were done with relatively late stage Alzheimer's patients. And then we decided that we have to move to earlier stages. And certainly when you're modifying risk factors, I think that definitely makes sense, probably with all trials. But that's raised a number of new terms like mild cognitive impairment, subjective cognitive impairment. Can you sort of differentiate those briefly for listeners?
Okay, thanks, Brian. Yes. So what these terms try and indicate is that there's a continuum of cognitive impairment, that we don't suddenly become demented overnight. Well, okay, in some cases you might, because you've had a massive stroke, or you had a terrible brain infection, or a road traffic accident, which caused severe brain injury. But in most cases of dementia, progress is slow. So when we only had clinical definitions, what was suggested was that this spectrum could be described as going from normal to having subjective problems, meaning that you thought you were more forgetful, you weren't as sharp as before, but on formal neuropsychological testing, you still weren't abnormal. And then you progress to something called mild cognitive impairment, where you had subjective problems, as well as objective evidence on neuropsychological testing that your memory wasn't as good as the population norm should be. And then finally, when the cognitive impairment became severe enough to interfere with your daily activities and your occupation, then a diagnosis of dementia was made. So there's this sort of long slope. But I have to say that this clinical definition has recently been supplanted by a more biological definition using biomarkers. So the current conception of Alzheimer's disease is that you can have Alzheimer's disease pathology even if you're asymptomatic. So you can have no symptoms, but your PET scan shows that you have amyloid, or your blood biomarkers show you have amyloid. So that's still Alzheimer's disease. You can have Alzheimer's disease associated with MCI, and you can have Alzheimer's disease associated with dementia. So AD no longer means Alzheimer's dementia. It now spans the whole clinical spectrum. And perhaps that's the way to go, because we do the same thing for cardiovascular disease. We don't say you only have cardiovascular disease if you have heart failure. You may have cardiovascular disease if you're asymptomatic, just like that poor Danish footballer.
For a trial like SINGER, I think we're all hopeful that it'll have positive outcomes. And
Yes.
At what stage do you think it'll work in, and what stage might be too late?
Okay, so
I'm
right.
asking you to speculate, obviously, but
Sure. And we have made our a sort of bet on this, because the inclusion criteria for SINGER is that we are recruiting people at risk for dementia. So we do not recruit people who already have dementia, and we're also excluding people who are very close to having dementia. So we have various sort of scales that we test people on to make sure that they are not too bad already, because I think that we think that these lifestyle changes would probably only be best suited for people who are early on in their disease course. And I think it gives us the best chance for seeing whether there's a result. So if we do see a result, then maybe you want to go and take your studies into patients with more severe problems. And the other reason why I think we are avoiding people with dementia right now is that there have been some studies showing, for example, that physical exercise or intensive physical exercise is not good for people with dementia.
And I think that this sort of multimodal intervention, looking at multiple lifestyle factors, is likely to have synergistic effects. And so it makes sense to put them all together. And that may have been underlie a lot of the success of FINGER.
Yes.
And I think a lot of us can see, excluding your last statement on people with AD and extensive exercise, but I think a lot of us can see the benefits of exercise and nutrition. And what about the cognitive training? I think that's been more controversial. What's your view on the role of cognitive training for people at different stages of dementia?
Well, one of the controversies about cognitive training is whether it's transferable. In other words, if you train very hard at doing a particular test, does it make you better at other tests? Or does it make you better in real life? So, for example, if you train very hard at Sudoku, does it help you write a novel? The answer is probably not. And so that's been the problem with cognitive training. So can you transfer the effect? Is it long lasting? And I think that what we are doing with our cognitive training is to say that it may have a benefit in addition to other lifestyle changes, but probably not alone by itself.
That's interesting.
Yes.
Let me come back to amyloid plaques, because this has been a topic of debate. I think the field was heavily focused on trying to make amyloid go away and various levels. And there's been success, at least in animals, at developing interventions that make amyloid get reduced. And yet the clinical studies have been, I think it's fair to say, underwhelming. What does that mean? Do you think that we're overestimating the role of plaques in the disease, or is there some other explanation for the difficulty in translating studies into human clinical trials in terms of the amyloid plaques?
Well, thanks, Brad. So it's a very hot topic at the moment with the FDA's approval of aducanumab, which many of you may know is the first disease-modifying trial, a disease-modifying treatment approved for Alzheimer's disease, which specifically targets amyloid. Now, I think that nobody would probably say that amyloid is the only cause for dementia and the only target that we should examine. But the fact is that it's the biggest target, the most well-studied target, and the one which has the strongest associations with future development of dementia. There may be other biomarkers out there, for example, tau, but even tau biomarkers, as you saw from the talk given by Joyce, are very strongly related to amyloid. So if we had other targets, we should address them, but we can't ignore the elephant in the room, which is amyloid. Now, yes, it is true that previous amyloid trials have not been anti-amyloid trials have not been successful. And a review of what went wrong could be the subject of another talk. But just to summarize, okay, the first thing that went wrong was that people launched themselves into human trials with active immunization far too early. They were too enthused by the animal experiments and probably didn't think through this carefully. And it led to a disaster because about 6% of patients who were immunized with this active anti-amyloid vaccine developed meningoencephalitis, and several died. So it wasn't a very good trial at all. And it kind of spooked the whole field, because even though we moved towards passive immunization, everybody was worried about amyloid treatment-induced changes in the brain using MRI, so inflammation, hemorrhage, and everybody was very hesitant. They used, I think, too low doses of the treatment. Didn't really shift amyloid very much because people thought if we shifted too much of the amyloid load, there would be problems. But as time has gone on, we found out two things. One, we were treating the wrong people. As I said to you earlier, even people with dementia, only about 70 to 80% of them have amyloid. And secondly, if you're going to target people at earlier stages of disease, the prevalence of amyloid positivity drops even further. So MCI is 50-50. So it's not until the aducanumab trial came along where they actually bit the bullet and decided to use PET to select patients. So nobody got into the trial if they didn't have a positive amyloid PET study. And they did, in their dose ranging study, several doses, and only the highest doses eliminated amyloid. And they went on to that in the clinical trial. But how they went on to do the phase 3 trial is probably an object lesson of how not to do it. I think they were really lucky to persuade the FDA to approve aducanumab, and I think the FDA probably approved aducanumab because they didn't want to stifle the current surge of interest in these treatments, and I think that the other treatments will probably surpass aducanumab.
This is a difficult question to answer, I know, but how big of an effect does this drug have, do you think, on slowing the progression?
Okay, so the results, if you believe them, suggest that there is a 22% reduction over 1.5 years in the rate of decline. So people still decline, but they don't decline as fast. So I think that if you believe that this 22% risk reduction is translated across all stages of disease, I think that you're most likely to benefit if you have very mild disease, because you're not going to progress very fast and you're going to slow it by a quarter. Whereas by comparison, if you had late disease, slowing things down by a quarter, by 22% may not be very clinically meaningful.
Yeah, well, we're getting a lot of questions, so I'm just going to ask one more and then I'll turn it over to Bibek.
Thanks.
This Singer study is fascinating, but it's a pretty robust intervention. People have to do a lot of different things. There's a lot of oversight. is this scalable if it works to a large population?
Yeah, so that's exactly what we're trying to do with our digital platform. We hope that by having a digital platform which brings people together at low cost, it will be scalable. Especially if we work closely together with the what's already available in the community.
Yeah, so that's great. So I'm going to bring feedback in because I know there's a lot of questions in the audience.
Sure.
Thanks, Dr. Chen, for the very nice talk. So just now you mentioned about the new amyloid drug. So one of the question here is about what is difference between active and passive immunization? You just mentioned about this.
Oh, okay. So active immunization is when you train, just as we are doing with COVID-19 interventions, you're training your own body system to produce antibodies. And this proved to be perhaps too much for Alzheimer's disease. Whereas passive immunization is the infusion of antibodies, which will have an effect, but then eventually will disappear and be metabolized. So for the passive intervention trials, it's not a one-off. You have to have infusions every month. So this is one of the major costs of the new treatments.
And the next question is will nutrition-rich diet and with intermittent fasting and regular exercise will help to prevent dementia? Because we all know that intermittent fasting is associated with healthy aging, and will it supplement with any nutrition supplements such as DHA or curcumin also help to reduce the risk of dementia?
So the short answer is I don't know. They are good ideas, but there's no real clinical trial proving it. And I think that intermittent fasting is a very interesting idea. We're examining it in animal models in our lab and other labs, but I think a lot more work needs to be done.
Yeah, and Dr. Chen, you just mentioned about the SINGER. There is about the cognitive training and physical training. But there's concrete studies have shown that which type of physical activity is better outcome, like weight training, aerobic, or strength, anything?
Not really. So I think that we have chosen to have a reasonable amount of training. And I think that it's of reasonable intensity and reasonable length. So I think that doing something worthwhile as regularly is going to be the answer.
If I can jump in there, I think that there's two different kinds of exercise benefits, right? There's building muscle mass from resistance training and bone strength, and there's also cardiovascular benefits that come from endurance exercise. Is it clear which of those is better in terms of cognitive health in old age?
I don't think we know that. I mean, Andrea probably knows that better than me, actually. But in SINGER, we're putting both strength training as well as aerobic exercise.
Yeah, great, Dr. Wilson. There is one question here. Maybe people are interested to know about SINGER. Can you tell us more about the age group and recruitment criteria in SINGER? From which age to age group people are going to be recruited for SINGER study? Okay,
so mid-60s to late 70s.
Any idea about the quality of sleep? Will it affect the accumulation of plaque or tau in the brain?
Yes, it's an interesting suggestion that quality of sleep may affect amyloid accumulation because good sleep may sort of clear amyloid. But again, that needs to be proved. And one of the problems, of course, is that we really don't know how, at least I don't know how, to really improve people's sleep in a clinical trial. So all we have now are associations, and we don't know whether it's the amyloid that's causing poor sleep or the poor sleep that's causing amyloid.
You mentioned about this the subjective cognitive impairment, mild cognitive impairment, it's a continuum of Alzheimer's disease. So if anybody wants to prevent an Alzheimer's disease, when should they start the taking care of health? It should start from childhood, or is there any genetic testing I can do in my mid-30s and find I have APOE positive, then I can be more careful? Is there any cutoff? When should I be careful?
Well, I think you should start by choosing your parents carefully.
That's not modifiable risk factor.
Well, and then of course, as I said as I showed in that paper from the Lancet Commission, there are early factors, midlife factors, and late life factors. So the most important early life factor, of course, is education. And then, of course, we know that many early factors may affect your risk of diabetes and hypertension. So we should pay attention to those things. And then in midlife, yes, we need to go and sort of be sure that we avoid smoking, try and make sure you monitor yourself for reversible risk factors like diabetes, hypertension. In late life, it's also very important to be sociable. And interesting things like, as you know, Vivek, preserving your hearing or getting hearing aids.
Yes, correct.
You say education, and maybe you could elaborate more on that, because is it education independent of socioeconomic status, or is it the benefits to socioeconomic status you get from education that are protective?
I think there have been good studies to show that it's education, regardless of your social status. And in fact, that's exactly why we should have education across the board, compulsory sort of high standard education for everybody.
And I think there are some of the people here, they are interested in SINgAPOR. So are you accepting candidates for this study now, or when will we start recruiting?
Yes.
How can they be recruited? Is there any way they can sign up, or who can they contact?
Okay, so Brian, I didn't put up our MACC website. I can share that.
Maybe either that, or we can put it on the
chat box. Yeah.
Our website afterwards, where the registration is.
Okay, we're happy to go and share our website, and the website gives some information on how to go and sort of volunteer to be screened.
Yeah, and I'll put it.
Thank you very much for your interest.
Too, so, yeah.
Yes. We warmly welcome you.
Yeah, Dr. Chen, now recently this new drug about amyloid clearance. But what about the tau? We are leaving the tau behind, or any clinical trial coming along on tau deposition?
Okay, so many Singaporeans had strong interest in this drug called Tau-X, but unfortunately, the Tau-X trials were not encouraging, and they have failed on several occasions and in different indications. So that's kind of sad. And most recently, there has been a monoclonal antibody trial on addressing tau, and that hasn't worked either. I think that tau is a difficult target. So firstly, tau is intraneuronal. So trying to get rid of something that's already inside the neurons may be beyond what antibody can do. I mean, amyloid, on the other hand, is extraneuronal in the and can be easily cleared. Also, I think that there is a very strong relationship between amyloid and tau, and that if you don't get rid of amyloid, you might not be able to get rid of tau in a meaningful way. So I think one very intriguing result from the aducanumab trial was that they did a very small step study in about, I think, 50 plus patients, where they did tau PET. And, I think that the expectation was that if you eliminated amyloid, tau would be stable and wouldn't increase. But contrary to expectations, not only was tau stable, it actually dropped. The higher the dose of aducanumab, the lower the tau burden. And not just globally, but also specifically in the areas which already had tau, it would appear that getting rid of amyloid also gets rid of tau.
Is there any mechanistic understanding as to why that happens?
No, I think it's just so stunning. Now, that of course needs to be replicated. It's only one small study. The larger phase 2 study of donanemab, which is a Lilly anti-amyloid treatment, showed very little difference in tau. So I don't know whether it's true or not. We'll have to see. But it is very surprising. Maybe too good to be true. I mean, not having any increase in tau is good enough for me.
there is one question about the cognitive training. Is Mahjong considered as a form of cognitive training? Do you want to tell us about what should we do to improve our cognitive performance?
Yeah, I think Mahjong is a great sort of activity. Not only does it cognitive training, it's also good for upper body strength.
I got taught Mahjong by some people in China, and I found it to be a very good way of lowering my economic status. So.
No, I think that the general advice we give all our patients in clinic is, do something that you like. And in addition, do something new. Okay, I think that just playing Mahjong every day as you've always done may not be the best idea.
Yeah, I've always heard it's like pushing your brain in new directions. That's really probably the most beneficial.
So play Mahjong and maybe play Gin Rummy as well. But for goodness sakes, don't hit the casinos.
Vivek, we have time for one or two more questions.
Yeah, let's take another questions. In SINGER, we are also including vascular risk factor control treatment. So
Yes.
there's one question: improving circulatory system or reversing atherosclerosis. Can it help to reduce risk factor dementia? Are we including this in our SINGER protocol?
Yes, I think that by managing risk factors, we anticipate that we will reduce not just overt strokes, but also silent strokes, and reduce cardiovascular disease. Now, does reduction of stroke or treatment of vascular risk factors, does it reduce dementia? Well, I think that there's pretty good evidence that it does. So you may be aware that the incidence rates of dementia is declining across the Western world. And it's not because we found a cure for Alzheimer's disease. It's probably because people have much better control of hypertension, diabetes, etc., than was previously possible. And in fact, one study in Canada, in Ontario, showed that soon after the state implemented a active stroke prevention program, rates of dementia dropped. So I think it's very promising. And that's hopefully one of the effects of SINGER. In SINGER also, we're encouraged by the results of something called the SPRINT MIND study. So SPRINT was a very large clinical trial trying to aim for lower blood pressure rates, 120 systolic rather than 140. So not only did they find that there was less cardiac events and strokes, etc., but there was also fewer people who converted from normal to MCI and fewer people who converted to dementia. So, I think that reducing vascular risk factors is very promising.
We probably better stop there, Vivek. And thanks a lot, Christopher. That was fascinating. I know it was a very we'll have to have you back because there were the most questions I've seen yet. So we didn't get to all of them.
Great to be here and great to be in the Healthy Longevity Program.
Great. And so I want to remind people to use the panelists and all attendees buttons to make comments on the show. Next week, we're going to have Dr. Brad Stanfield. He's a general practitioner at Devonport Health Centre in New Zealand, and he'll be talking about what he does for people who are interested in extending longevity. And I just want to point out that he also has a great podcast where he tries to break down new findings in the aging research field for everyone to understand. So I think he'll be a really interesting speaker next week, and he can answer a lot of those questions about what should I do if I want to live a longer, healthier life right now. And with that, I want to leave you, and a lot of you, as you're approaching 65, we tell people don't retire, find something new to do, find a new job, find a new career. So I want to show you a video of what some women found as a new career in China.
like sunshine, like springtime, like something's in the water and I'm taking a deep dive. I'm feeling so weightless, like I'm gonna make it, and nothing in the universe can take this. I can see it clearly now, nothing gonna bring me down.